John.
Thank you, my lady. Dr. Cooper, I'd like to explore with you next the different ways in which Public Health Wales provided advice to the Welsh Government during the pandemic. Can we start, please, by confirming that Public Health Wales did not take part in any informal or private communications, such as WhatsApp groups with ministers or senior servants that inform significant decision-making,
No.
and as such doesn't hold any records?
No.
You say that in the context of Covid-19, the requests for advice from the government increased significantly. When did that increase happen? Was it gradually over the whole time period, or did it ramp up after a certain time?
I would say from around about middle of February, it started to increase. We were already providing information through our engagement predominantly with the Chief Medical Officer at that point. And our teams were attending daily incident management teams with the rest of the UK counterparts. So there was situational awareness information coming through that we were sharing. But really from probably the second half of February and then from early March, it really rose exponentially.
Thank you. Can I ask you about advice notes, please? You say in your statement that the first formal advice note to the Welsh Government was on the 12th of October 2020. How was advice provided by Public Health Wales prior to that, so in the period between January 2020 and October 2020?
So we were continuing to provide multiple pieces of advice between that time. And the reason perhaps to differentiate this from the 12th of October is that was the first time we put in place a process that was more systematic with Welsh Government, because there were so many requests coming in that we wanted to create something that was more of a definitive position. So prior to that, we were asked for advice from different policy leads around sampling, testing, infection prevention and control. The provision of the requests for those advice came through emails. They came through, we were asked to provide advice during meetings. One particular example is when the Chief Medical Officer wrote to me on the 22nd of April asking us to develop the Health Protection Response Plan, which obviously was a plan that we put forward. And our information back took the guise of advice that my team may give during meetings, through to us putting documented advice in where requested, where it would be a briefing note or it would be an advice note. But that predated, if you like, the new model that we were doing from October. So that didn't mean we didn't provide advice before October. We provided a multiplicity of advice. It was just the system was more refined when we got to October.
Thank you. Could I ask you just to slow down a little bit
Sorry.
so that the transcriber can keep up? Thank you. So is it fair to say that in the period up to October 2020, there were multiple requests from multiple contacts on multiple topics? And is it fair to say that a record would not have been kept of all of those requests and of all of the advice provided by Public Health Wales in that initial period?
And that was one of the reasons why we moved to the October model, not in a systematised, tracked way. Obviously, every individual has got the records, and we've pulled a lot together for the inquiry. But as far as a registered approach going forward, that was one of the learning points for us, that we really needed that to happen and to elevate the level of advice that we were given in the way that we were imparting it.
So is it fair to say that Public Health Wales does not have a comprehensive record of all of the advice it provided during the pandemic?
Not from the beginning, and really from October onwards.
And would you accept that that initial period was a crucial period in the pandemic?
Yes, it was a very crucial period.
Can I ask you, please, about your contact with ministers? In your corporate statement, you say that the advice provided to the Welsh Government by Public Health Wales appeared to be well received, and that you understood that the advice was incorporated into the decision-making process. Are you able to say with any certainty what advice was accepted or rejected, or what weight the government placed on certain pieces of advice?
Really good question. I think on occasion we could, because we could triangulate it back to the advice that we were giving. So, for example, I mentioned the Public Health Protection Response Plan. That became the operational model for what was then published on the 13th of May, which was Test, Trace, Protect strategy. So we could see the derivative of that from the advice that we'd given. We knew that, particularly when we got into that more formative advice process from October, we knew that TAG was including our advice either as copied and pasted into advice or as an appendix into the advice they were providing to Cabinet, particularly around looking at consideration of NPIs, restrictions, really from that autumn point onwards. However, we weren't able to track every single piece of advice and whether or not that was taken on. Obviously, we were one part of the advice suite that ministers were considering in order to make decisions. So they would weigh up other elements that, so to varying degrees, would include ours, I would have anticipated.
And is it right to say that in those forums it would be a case of Public Health Wales being one of a number of people providing advice and then the decision being made at a later date in a different place? Yes,
and really typical examples of that as when Wales went into the local restriction time, the First Minister would convene a group of the respective leaders, chief executives for local authorities, chairs and chief execs of health boards and other key partners in considering what the situational awareness was in order to consider going into a local lockdown. The decision wasn't made at the meeting. We would provide advice, but the decision was made after the meeting. So it was predominantly more of a multi-agency approach, yes.
In Module 2A, Professor Nick Finn gave evidence. He was Director of Public Health Services for Public Health Scotland in January 2021, but at the start of the pandemic, he was Deputy Director for the National Infection Service within Public Health England. And so from his experience of working within both those organisations, he was able to provide some interesting perspectives about the way in which things were approached differently in those two nations. With regard to Public Health Scotland, what he said was that there were minimal opportunities to provide ministers with a first-hand account of the thoughts of senior staff in Public Health Scotland, or to make them aware of the practical implications of policy decisions. He said the main mechanism by which Public Health Scotland was able to provide advice to Scottish Government was through the National Incident Management Team. Is that similar to what happened with Public Health Wales?
No, I would say we were, whilst we didn't make the decisions, obviously Welsh Government ministers made the decisions, we worked very closely with them. So I all the way through, obviously was working, as my team was, very closely with the Chief Medical Officer, and so the Chief Medical Officer was obviously able to share direct hand any comments into ministers, similarly with Andrew Goodall as Director General. But we also attended a considerable number of meetings with ministers, and we've shared in the statement some of the key ones, but there are others, where we were able to share our thoughts on what the latest evidence was, not only for Wales but for other countries. There were also specific periods where, for example, we had a number of outbreaks in food and meat production factories where ministers would set up. There were a number of meetings where there were a number of ministers attending those meetings and other partners, where again at first hand we were able to share the information. And from about October in 2020, myself and my chair reverted to what was happening pre-COVID, where we would have normally around about bi-monthly meetings with the Minister for Health as Public Health Wales and the Minister for Health with the Director General or the Chief Medical Officer. So we were able, by the time we got to October, to revert back to those, which was helpful because we could give quite a specific element of our views, but also increasingly the broader harm impact of COVID.
Professor Finn said that in relation to Public Health England, that he was involved in face-to-face discussions with ministers. He was in the room providing direct advice, advising on what introducing policy could mean on the ground, what the relevant issues were that had to be thought through. And he said he thought being in the same room, advising and pointing out the implications was really important. Do you agree with that?
Absolutely.
And you say that Public Health Wales did have that direct line to ministers.
We did. Certainly up until the Christmas time, I would say, or before September, the majority of those occasions were with others. And we would share information in advance, so we may be asked for briefing notes for the Chief Medical Officer or the Director General to share. But I think one pivotal moment was on the 19th of December 2020, when 2 of my team were asked to join a cabinet meeting to give direct advice. And obviously we were in the Kent variant phase at that point. And we'd preceded that by issuing a number of advice notes. And so Dr. Chris Williams, who you met last week, and Catherine Moore, one of our senior clinical scientists, virologists, who submitted a Rule 9 statement, attended that meeting directly with the Cabinet to give that first-hand advice. So I wouldn't say that there was a time where when we were in that position, we were invited to understand. Similarly, in August 2020, the First Minister invited us to attend a cabinet meeting, myself and one of my former directors, Director of Policy and International Health, to share the international learning that was happening. Unfortunately, there were technology problems, so we couldn't do the direct engagement with them. But that was that. It makes such a difference to be in the room. Yes.
Is it fair to say that there were specific occasions where you did have direct meetings with ministers, but was that direct line always open throughout the pandemic?
Well,
can I work through an example?
Yes, please do.
So Professor Nick Finn said that in Scotland there was a situation where the government had decided that they should be checking up on people to make sure that they were maintaining quarantine, and that led to a reasonably robust exchange between the Chief Executive of Public Health Scotland and the Scottish Government, where Public Health Scotland was saying it just wasn't a feasible option. Am I right in understanding that something similar happened in Wales, where Dr Sandifer says that he received an email from the Welsh Government on the 31st of May 2020 with an expectation that Public Health Wales would write to all overseas travellers by recorded delivery letter, followed by telephone contact for monitoring. And he had to write back, pointing out the difficulties with that. First of all, Public Health Wales could not access the passenger locator form database held by the Home Office. And secondly, did not have the operational requirements to be able to send out 150 recorded delivery letters a day, followed by daily phone calls, 14 days for each arrival. Is that the kind of misunderstanding that could have been avoided if ministers had been in the room with Dr Sandifer or others leading the response?
Well, that's a really good example because, and perhaps you can clarify with Dr Sandifer tomorrow, but my recollection, if I recall correctly, is that Quentin, Dr Sandifer, was invited to a discussion with the First Minister on this precise issue and expressed the logistical challenges of it. And I think, again, please check with Quentin tomorrow, but I think we were saying we didn't have a problem in doing it, but actually the process was too cumbersome and not realistic, that we would prefer to do it by email in a safe, information-governed way. And I understand that the First Minister accepted that.
Thank you. I want to move on, please, to multi-agency meetings that Public Health Wales was involved in. Starting with meetings with the Chief Medical Officer for Wales, and I'm going to try and deal with these broadly, chronologically, from when they were established. So you say that informal catch-up meetings happened with the Chief Medical Officer for Wales starting from the 26th of January 2020. What did you mean by informal catch-up meetings?
So these really took the nature of a quick half-hour what we were learning internationally, what were the concerns we had, where was Wales at. No decisions were made at those meetings, and they were very similar to what we'd have done pre-COVID in a quite a relaxed catch-up way. And on occasion, the Chief Medical Officer may ask us to provide advice to him on X. But they were not, they weren't formal, structured agenda. We wouldn't share an agenda. It was very much a rapid situational rep, if you like.
Bearing in mind that Public Health Wales got its first briefing through Public Health England on the 8th of January, do you think that those meetings with the Chief Medical Officer should have started earlier?
Well, my understanding, and again, Quentin is closer to this than me, so my understanding is that I think the first meeting with Public Health England was the 7th. We issued a briefing to the NHS on the 8th, and then again on the 10th. But the team, in auspices of Quentin, were already very close in communications with the Chief Medical Officer. So it wasn't that no engagement happened. It was the fact that from the 26th of January, we just scheduled into the diary, whether we needed them or not, a quick half-hour situation report. Prior to that, there was just constant engagement between the team, the Chief Medical Officer, and officers working in the Chief Medical Officer's office. So really, from that point in time, we were working in synchrony with him.
And albeit these were quick half-an-hour sessions, were they recorded?
No.
Do you think they should have been recorded?
Yeah, I think if we were to run this again, just having a tracker, as I say, there was no agenda beforehand, and there weren't decisions made. That's not the purpose, and they were happening so quickly. But I do think it's helpful to have a tracker, even if it's just these areas were discussed, and Public Health Wales was requested to do X. The situation was happening so quickly, but I think that's an important learning point.
Can I ask you about the Public Health Wales, Welsh Government, Wales Ambulance Service, NHS Trust meetings? So these were daily informal catch-ups, is that right? Starting on the 28th of January 2020. Up until the 3rd of March 2020.
As far as I'm aware, I wasn't directly involved in them, but yes, as far as I'm aware.
And do you know what the purpose of those meetings were?
Yes, I think it was very much... we work very closely as Category 1 responders, and Welsh Ambulance Service Trust is a key responder. So when we're into an incident, we engage with them regularly. And at that time, it was at the beginning of that time, COVID was deemed to be a high consequence infectious disease, and so the transportation for the ambulance service of patients who have a potential or have a high consequence infectious disease is significant for them logistically. So my understanding is those meetings were set up originally to work through with them how they would go about undertaking that transport, and then of course subsequently it was de-designated as a high consequence infection, and so they fell away, and the next phase of the pandemic kicked in, if you like. Albeit
COVID-19 was designated formally as a high consequence infectious disease. Is it right that from the very outset it was at least out of an abundance of caution treated as if it was?
Yes.
Bearing that in mind, do you think that the meetings with the ambulance trust should have happened earlier to warn them about potential cases coming in?
We were briefing the Ambulance Trust, as with the rest of the NHS. So when we sent the briefing out on the 8th and the 10th, we sent it out to the NHS, and that's all of the organisations. So again, whilst the date of the meeting was X date, there were multiple engagements happening with the ambulance service. And I can remember personally on a Sunday being in our offices in early February, where we had a potential case, and being on a conference call, because I was helping in the contact centre, because the ambulance service were trying to work out the logistics with the health board. So they were aware of it, of the risks of COVID at the same time as we were when we briefed the NHS.
And talking about the NHS, the Health and Social Services Group, Coronavirus Planning and Response Group, we dealt with that with Dr. Goodall this morning. But that group started on the 20th of February 2020. You've told us that prior to that you were in contact with the NHS and the Ambulance Trust, is that right? The First Minister, Mark Drakeford, has said in his statement that at times the relationship between the Health and Social Services Group in Welsh Government and Public Health Wales was difficult. Do you agree with that?
Without an example, it would be helpful if if there was an example. Having read that paragraph, the beginning of the paragraph is in the context of data, I think.
That's right, data and modelling. He goes on to say, if it assists, that during the pandemic, he says we needed it to be more in the delivery space, such as ramping up testing capacity, but it struggled to be so effective. And then he goes on to say that as ministers, you only hear about what goes wrong.
So if I could perhaps cover the first element around the beginning
Yes.
of that paragraph around data, and then perhaps make a comment around scaling up services, particularly testing. So there were times early on, I would say, earlier on, where there was such a rapidity of questions and requests for data, understandably, from colleagues in Welsh Government, from ministers, and I mean multiple times in an hour through the day. And we had put all of our data analysts from across the organisation into our communicable disease surveillance centre. And so to keep up with those was a challenge. Sometimes on occasion, there were the same question coming from different parts of the Health and Social Services group. And later in the pandemic, we created a group that could coordinate that better. And we tried a number of times with that. And also there were times where, through the course of the pandemic, we were asked to add additional fields to the population surveillance dashboard that we'd published, which expanded rapidly. And I can remember an engagement with Andrew Goodall I think it was probably in the summer, where we'd been asked to add a significant number of additional fields, and it just logistically wasn't possible in the time they asked for if we wanted to have the quality of the data integrity, because in order to do it, we had to test the source data. So we had to negotiate on occasion. So that's what I'm assuming, that's how I interpret the First Minister's comments. I would say that there were some frustrations from our side as well, and every few months we tried to create that a better control system. The meeting I referred to was, I think, from September, October. A number of our team met weekly with the Chief Statistician for Health, so that they could plan in advance as we were getting into adding vaccinations, as we were getting more knowledge. And again, that system helps improve that coordination. In relation to the First Minister's comments about the delivery elements
Yes.
of the organisation. So going into COVID, we had around 2,000 staff. 2/3 of those staff were in our Public Health Services Directorate that Dr. Sandifer led at that time. And that directorate delivers all of the microbiology for Wales, with the exception of 2 health boards, all of the 8 national screening programmes for Wales, and all of the health protection technical service for Wales. So service delivery was a big part of the organisation. The challenge around testing, and I don't know whether you want me to explore that now.
Well, I was going to ask you if it was Public Health Wales's view that it was for that organisation to be carrying out mass testing.
So, if I may, so there is the end-to-end process of getting a result from a test begins with sampling, which is the swab. So, without the swab being taken, the swab doesn't arrive. We can't do the test, and the test result doesn't come out. So, a lot of the time, people refer to testing as a catch-all phrase, but actually, it's the taking of the swab and doing the test. Now, our role predominantly is doing the test in the lab. That's what we do. Early in the pandemic, we did do the community swabbing as the odd patient case came through, because we were supporting health boards in ramping up their capacity and capability to do that. And that was happening through February. And then I think the Chief Medical Officer wrote on the 10th of February to health board chief execs, clarifying expectations of establishing community testing units, which were the swabbing units. So our role absolutely wasn't to do the swabbing part of testing, although we did it for the first 2 months or so to help health boards. Our role was about the diagnostic element of testing. And I think you have in the statement that we were really fortunate with our team to have created a domestic test at the end of January, which the Chief Medical Officer then approved at the 7th of February. And that enabled us to have that domestic resilience in complementary to what was happening in the UK government. Now, at that time, every country pretty much in the world was competing for the ability to test. And again, if I may, there are three critical things to testing. One is having the staff. Two is having the equipment, the platforms, the machines. And the third is having the chemicals. So if any one of those are significantly dampened, you cannot optimise testing. So we had the staff to do reasonably high volume testing of certainly up to 5,000, which we got to at the beginning of May. We had investment from Welsh Government in 2019 to diversify our machines across Wales, which meant that we could use different test kits and we weren't overly reliant on one or two companies. And in March, we procured more of those. The biggest challenge was the chemicals.
Thank you. Duncan Selby, who was the Chief Executive of Public Health England, told the inquiry in Module 1 that his understanding was that Public Health England would create and roll out the test, but then it would be rolled out to the NHS, and it was never an assumption, as far as he was concerned, that mass testing would be carried out by Public Health England. Is that a similar understanding that Public Health Wales had about its role?
We're designed slightly differently. So within our core functions is actually doing microbiology diagnostics.
On a mass scale?
Well, for the NHS. So if you get admitted through the emergency department with a potential infection, the sample's taken, and it's our laboratories based in hospitals that would do that infectious disease testing. And we have some international leading units within that, apart from an Iron Bevan Health Board and Cwmtaf Morgannwg Health Board, who have retained some services, but we work very closely with them. So we were, if you like, the NHS's testing service for infectious disease, whereas Public Health England have got specialist virology laboratories for, if you like, more the high consequence infectious diseases.
Thank you. Can I ask you about the Public Health Wales Health Board meetings, please, which started in February 2020? Did those meetings support the early implementation of home and community testing facilities across Wales? You say in the absence of other structured response arrangements.
So I think you may be referring to the additional meetings that my team put in place with directors of public health in health boards. I think those were in addition to that, we were meeting with health boards. Oh, sorry.
I've got meetings with health boards starting in February, and then meetings with directors of public health in March.
Yeah, sorry. We had so many meetings. Apologies. I think you may be alluding to in early February. I contacted my colleagues, health board chief executive, suggesting that we did one-to-one organisation-to-organisation calls with them. And yes, that was very much about, and I think I shared the agenda, where they were, where we were at as a country, where they felt they were in preparedness, had they done the training for face masks, how advanced were they in setting up their community swabbing. So we did those very positively with all of the NHS organisations, and I think I shared with you the capturing of the output of those as emails that I sent on to the Chief Medical Officer. Soon after that, we met regularly anyway as Chief Executives with Welsh Government, so that rhythm went in I think that started at end of February. And then, as I mentioned earlier, the more rapid, frequent directors of public health meetings were put in place.
Thank you. I've got one more group I want to ask you about. It's the Public Health Strategic Coordinating Support Group. Can you tell us what the purpose of that group was and why it was established?
Yes, so that just came out of learning from the Ebola virus disease outbreak. And during, that was 2014, 2015, if I recall, during that we were very heavily involved in working with our partners across Wales in anticipation, because it was a real threat at that time. And the local resilience fora were also engaged in anticipation of any potential case that came in. what we identified, and again, Dr. Sandifer may be better to elaborate on this because he led on it. What we found at the time was Public Health Wales attending the 4 local resilience fora, having very similar conversations with them at a busy time, and also them not hearing the feedback from their colleagues. A similar public health strategic coordination group was set up during that time. And so very early on, under Quentin's leadership, was the suggestion, I think we need to do similarly. So I understand that Quentin and colleagues connected with local resilience fora partners who we worked very closely with throughout the years. And it was proposed to establish the COVID Public Health Strategic Coordinating Support Group, and that was agreed to, and that started around about 25th of March.
23rd of March, the date of the first lockdown.
Yes.
Do you think that, bearing in mind the important role that local resilience fora and local government played in the response to the pandemic, that they should have been involved at an earlier stage?
Yes, I'm not sure exactly when colleagues in Welsh Government directly through their civil contingencies group engaged with them. So it could be that it's much earlier. I do think, though, we felt that it was, on occasion, we were holding the hands of the NHS and running forward at speed, and they were holding back. They were holding the hands as well. That we were in a position where we felt we could see what was highly probable coming down the line by just observing what was happening internationally, and that it was going to move to a whole of society situation. And so, again, I can't comment on Welsh Government when Welsh Government connected through the local resilience fora to engage with them. We, however, were connecting regularly. So on the 25th of February, I asked the team if we could establish, if we could run an exercise for a potential lockdown. And I spoke to the Chief Constable of South Wales Police the following day. And so we brought all the local resilience fora together for that exercise on the 3rd of March to test that out. So they were engaged with us, but I don't know when it was formal from a Welsh Government route.
Thank you. You've alluded to it already, but you made a comment just shortly before about there being so many groups. Do you think that the routes through which advice was provided to the Welsh Government could or should have been simplified?
I think in the early months, there were as I said earlier, there were multiple contacts. When systems started to be put in place, when TAG was put in place, I think that really was the point at which advice was much more helpfully streamlined, because there was a system in place. There were designated groups, subgroups that evolved over time, because the advice was about everything. And so I think it's that divergent activity and then structure bit gets put in place, which creates organisation within a very challenged environment. So the point, from my perspective, I think the point that TAG was established made it earlier. I'm not sure. Perhaps if that had been established earlier, maybe that would have made it more streamlined.
Do you think that all the various groups facilitated effective multi-agency working?
I didn't attend a lot of the groups, so I may not be the best to answer. I think it got clearer as the pandemic went on, because it was frenetic in the first couple of months. And then, as I say, as the Health Protection Response Plan helped, because it created organisation. It created a structure, a national, a regional, a local structure. And Welsh Government then wrapped its own meetings around that. And those were local authorities and health boards. And I think that was probably the first time where that there was that coming together of conversations and sharing and decisions of local authorities and health boards in a way of tackling COVID.
Can we move on to a new topic, please? The provision of data. The inquiry understands that one of the ways Public Health Wales supported the Welsh Government during the pandemic was through the provision of data. Can you set out, please, the kinds of data that Public Health Wales provided to the government?
Yes, and it changed through the course, as you can imagine, of the pandemic. So to begin with, it was very much about looking at the course of the pandemic on how it was impacting on the population. So the impact that cases, number of cases, the positivity elements of it, where those cases were happening, and then over the course of the first 6 to 7 weeks, we were able then to create more disaggregated data at a local authority level. So the course of the infection. We also provided data in relation to genomic analysis. So the genome sequencing of COVID, we were very fortunate in Public Health Wales and Wales in having a very strong pathogen genomics unit that we'd had for a couple of years. So we made the decision to scale that up very early on. And that was pivotal. And at times we were 3rd or 4th in the world in the number of genome sequenced. So that kind of data not only helped us look at outbreaks to identify where potential source or interrelationships between cases connected to that outbreak were and inform public health action, but they also allowed us to track the variants and the mutations of coronavirus coming through. Then thirdly, we did a lot of work around, obviously, the vaccination data as vaccination started. At the outset, we really struggled with collecting data relating to ethnicity and data relating to protected characteristics because it wasn't collected routinely to the level that we would have wanted in the NHS going into COVID. So when we set up with partners, Wales set up the information system for contact tracing in June. That allowed us to add data in there. And similarly, when we set up the data system for vaccination, allowed us to add a lot more data on ethnicity and protected characteristics. And then finally, just as examples, in April of 2020, as an organisation, we wanted to travel alongside the public on this. So we began a weekly public engagement survey, which is how we're doing in Wales, with 600 to 700 people. And we asked the population some continuous questions around health and well-being, their self-reported state, and also questions in advance of vaccinations or restrictions. And that information was published. We published it all the time, but it also enabled Welsh Government to track that in informing. And then perhaps, if I may, just finally, what we also set up in April, following a discussion with the Chief Medical Officer and myself, we have a World Health Organization collaborating centre. We wanted to track what was happening internationally, so the team collected data and formulated it into a weekly, then fortnightly, then monthly international horizon scanning and learning report. So we looked at the impact on children and young people, we looked at the impact on disability, we looked at how countries were scaling up the functions of a pandemic, and then finally we did health impact assessments of the impact of COVID on different population groups and the impact of different restrictions on people. So there was some broader population health data that we fed in as well.
Thank you. Can I just clarify one thing that you said? Is it right that during the pandemic, Public Health Wales did not have access to data in relation to age, sex, ethnicity, level of deprivation, or population density region? And is it the case that all of that is now available?
We had some of that going into the pandemic. We and again, Dr. Chris Williams, who you interviewed last week, is closer to the specifics of it. But we did have the data that was collected on the NHS patient administration system, which has got age, sex, address, etc. What the two, I would say, particular challenges, though, is that the specific nature of, the full demographics that represent the nation we didn't have those pieces of data. And so the team were trying to be creative in trying to assess the impact on Black, Asian and minority ethnic people, for example. And so we used a piece of software that could provide some sort of proxy in the absence of data. The other sector that was really challenged around data was the care home sector. And that was a significant challenge. It got better through the pandemic, but the capturing of the data that I'm sure care homes capture every day, but there wasn't a system that really could be relied on for us to help inform action or look at the reality of what was happening in any sort of systematized data way.
Thank you. And before we leave this topic, could I ask you to look at one document, please?
Of course.
It's INQ 000299607, and at page 7, paragraph 1.12, this is from a review of the Health and Social Services Group response structure to Covid-19 document, and it says there was a multitude of dashboards being prepared for different purposes, sometimes with similar but different data flows. In terms of Public Health Wales, this appeared to be done without any regard to what else was happening in the system, leading to duplication of similar outputs between Public Health Wales and Welsh Government and creating confusion in the media and to the public. Do you have any comments on that?
Yes, I mean, I think we have always, before COVID, we have the function of communicable disease surveillance. So as an organisation, we will always track communicable disease. What we were being asked to do was expand that in depth and breadth. Now, what I can't say is that every time we expanded it, that there was no time where we expanded it where we didn't, it wasn't as a request of Welsh Government. So a lot of our expansion of the dashboards was because, understandably, colleagues in Welsh Government were asking us to do that. I do think, however, that it could have been connected better and should be connected better going forward, so that on occasion, and I think Chris may have given this evidence, we were sharing data with Welsh Government, having presented it in one way, and then the same questions were being presented, the answers to the same questions were being presented in a different way. So I think it would have, going forward, the complementary skills and agreeing what's the best way to design or present it would be helpful. Final comment I would say is that is also the data was presented for different audiences. So we were presenting, we were providing data obviously into Welsh Government, but we're also presenting data as much as we could publicly. And I think the Knowledge Advisory Service in Welsh Government was, and I could be wrong, was more around data for Welsh Government interrogation and use. So again, going forward, being clear about how we work together, not to duplicate, but to be better on the question. That's one of the reasons why we set up the meeting with the Chief Statistician, which started in October 2020, so that we were really clear together and we could plan what that if you like, the next steps would be and who was responsible for them.
Thank you. I'm going to move on now to a different topic, which is on capacity and funding. Dr. Sandifer in the Module 1 corporate statement says that at the start of 2020, the health protection services in Public Health Wales were underpowered. Do you agree with that statement?
I would agree, yes.
In the corporate statement for this module, you describe scaling up Public Health Wales's response as one of the key challenges that you faced in responding to the pandemic. How was that challenging?
So if I pick the three functions, and before I do it, I think it's fair to say that in 2018, we flagged to the Chief Medical Officer in Welsh Government the concerns that we had, that we needed to build more resilience around our health protection, microbiology, surveillance services. And over the course of about 6 months, we did workshops with the NHS and partners together in tandem with Welsh Government. And then in 2019, we put a business case in to expand health protection, microbiology and surveillance services in order to build pandemic preparedness and resilience. And and that was approved in part. And then, of course, that was I think that was around about, I could be wrong, but September 2019, and then of course COVID hit. So we were able, though, to avail of additional funding then for new platforms, new pieces of equipment,
which we're going to cover.
Okay.
So the inquiry heard in Module 1 about the fragility of the, particularly the microbiology services, and heard that the system for dealing with testing, diagnosis and frontline support was inadequate and not fit for purpose and was struggling to deliver on a day-to-day basis. Is that right?
I think in the first few months for us, it was a real challenge, not because of so much the platforms, because we had diversified them. But the biggest challenge was getting access to the chemicals. That was significant. What I would say is in March we procured additional platforms, and then in August we put a business case in for 164 additional staff, which were approved, and you'll see in the statement more equipment. But
so we'll address those improvements that were made during the pandemic, but just sticking to the situation as at January 2020. The funding had come in from the government. Can you tell us what improvements had actually been made at that stage in terms of the infrastructure or workforce?
Prior to January 2020?
Or at the time that the pandemic struck?
Yeah, sorry. So we had procured additional pieces of equipment to be based in local hospitals, which means that their results could be done rapidly, locally, without having to be transported to another part of Wales to be tested.
In how many hospitals?
I think we had 9. I will go away and confirm if that's okay. I think we had 9 what we call hot labs, which are rapid diagnostics.
So you had 9 hot labs already in January?
Yeah, yes. If I will check on the number, but I'm pretty sure it was 9. And that allowed for a rapid diagnostics. We also had some additional communicable disease surveillance teams that were starting to be appointed. I think we'd appointed a couple of additional consultants. I'm not sure if we'd managed to appoint any additional health protection team, because it was, by the time it was approved in, say, September 2019, to mobilise and recruit all of those, we went straight into the pandemic. But nevertheless, the diagnostic infrastructure was better, but it still would not have been enough at all to scale up to the level that we needed it to.
And just to clarify, with regard to high consequence infectious diseases, is it right that they had to be tested in specific labs,
yes.
I think level 3 labs? And is it right that in January 2020 that testing was still being done in England?
Yes.
And so there was no testing capacity within Wales in relation to HCIDs? In your corporate statement, you say, Dr. Cooper, that in exercising its role and functions, Public Health Wales was not held back in any way by the funding made available by the Welsh Government. There are no examples of insufficient funding curtailing the ability to fulfil Public Health Wales's role and functions in a timely manner in relation to the pandemic. Do you stand by that?
I do. There were sometimes on the business cases it took a little bit longer than we'd have liked for them to be approved, but and on one occasion it was less staff that we'd asked for, but nevertheless it was a significant increase. So I don't have an issue with every time we put a business case in. Most of the time it was very rapidly approved, and so we were fortunate actually in that respect.
So I do want to explore some examples with you, and it is the case, isn't it, that when Public Health Wales set out a business case for additional funding, it was granted by the government. But in terms of timing, on the 24th of March 2020, you submitted a request for capital funding for COVID-19 testing platforms to be placed at all microbiology laboratories in Wales, and that was to increase testing capacity. Is that right? And that was granted fairly quickly the next day on the 25th of March 2020. Is there a reason why that wasn't applied for prior to the 24th of March?
Well, my understanding is, and again, that the 2019, I may need to come back and give you clarity around the specifics of it, but we had purchased additional platforms during 2019. But our team
This is in relation to COVID-19 testing platforms?
Yeah, so the platforms to test COVID-19 are, they're not unique for COVID-19. So they could test a number of respiratory viruses or other viruses. So you can have one piece of equipment that can test a number. So it was about making sure we could expand those that could test for COVID-19. But we could see what was coming down the line. So similarly, we knew we had to scale up our platforms, our staff, our chemicals. And that was, and in March particularly, trying to increase our testing capacity, competing with the global supply chain was a challenge. And on occasion, whilst we had the approval to purchase them, we struggled to get some equipment from South Korea. And we were in negotiations with Scotland to try and have a charter flight come down. So even though they were approved, they were still a challenge to get into the country.
But it's right, isn't it, that in that very crucial initial period, knowing what you knew about what was coming down the line, you knew that there was a need to scale up. So why wasn't the application for additional funding made earlier?
I don't know.
Can we move on to the 7th of May 2020, when a business case was submitted for the establishment of an additional microbiology testing lab?
Yes.
That was the Imperial Park IP5 lab, and that primarily focused on delivering serological testing for COVID-19. Can you explain what that is, please?
Yes, so the swab test that people are familiar with measures something called the antigen, which is that someone has COVID at that time. What serological is blood tests, and what that blood tests do is it measures whether someone has had COVID within the last number of months or so. And so the Imperial Park lab initially was for antibodies, serological testing. That did change over time to antigen testing as well.
How important was that new lab to the response?
That was very important to us at the time, because it allowed us to do very large throughput testing. That was in advance of the Lighthouse labs coming on board, as I'm sure you're about to.
Before I do, it's right, isn't it, that new lab became operational in January 2021? And so the same question, why wasn't additional funding applied for before May 2020 for that important new lab?
And if I may, the reason why there was a delay is that the lab was novated to the Department of Health and Social Care.
That was later in August.
That's right, yes.
But the application for funding was in May.
Yes, I think that it's absolutely fair questions. I think from as we were travelling through the pandemic, and particularly in those early months, while we knew it was coming down the line, we were still unclear about what the scale was going to be and how long it was going to be for. And putting a business case in really early when we've only got maybe 10 cases is a challenge to seek approval. When the business cases went in March, it was much clearer that we were, obviously the pandemic had been declared, and so it was a much more logical sequence of approvals. For the May, though, so the business case went in May because we weren't sure whether we'd be able to avail of the Lighthouse lab capacity at that time, which meant that we really needed to scale up to another level in Wales. But I think it's a fair question. I don't know the specifics of why for the large lab didn't we apply earlier, but I think reflecting on your March one, we wouldn't have got a business case through with a handful of cases probably if it had been earlier than that.
You applied for funding for 6 additional hot labs.
Yes.
In August 2020, and at the same time recruited 162 whole-time equivalent staff to the microbiology service at Public Health Wales. It was known, wasn't it, that there was a lack of microbiology staff at the beginning of the pandemic. Why did it take so long to apply for additional funding for that additional resource? Yeah,
well, similarly, we were trying to, we were reasonable with the number of our staff, and as I said, we were able to appoint some in that 2019. The challenge was that the more we were learning about the transmissibility and the impact of cases in Wales, the more the expansive reality of we're in this for a long time. We're going to need to grow to a sustainable resource. So I think Dr. Goodall mentioned earlier that initially they thought it would be maybe a 13-week epidemic. But of course, by the time we got into heading up again by the middle of the year to August or so, and that was the tipping point really, when towards the end of August we saw the rates really kicking up again, and that was alpha kicking in, then it was clear that this is going to be a rolling pandemic. And so for the government to commit to recurrent resource, expensive resource for 164 new people, that's a big recurrent amount. And together with all of the additional investment, again, earlier on, I think the wisdom was, I think amongst some was, well, actually, this may be more self-limiting than it became. And then, again, as Dr. Goodall mentioned this morning, it was clear that they needed to have recurrent infrastructure that was here. So I think that was really the timing, that spike in August, and the discussions we were having with Welsh Government in August was, how are we going to do rapid turnaround time when we've got another wave coming, and test, trace, protect is bedding in, but it needs to expand to the next level. So I think that was really more about the situation at the time.
Thank you. So that's microbiology staff.
Yes.
I just want to do one more example, please, in relation to health protection staff. There was an application, wasn't there, in November 2020 to increase resource in that department. And in fact, there were some negotiations with the government and it was finally approved in February 2021. You recruited, didn't you, an additional 109 whole-time equivalent health protection staff. Do you think that if that application had been made much earlier and had been granted much earlier, then you may not have had to suspend some of the other essential services that Public Health Wales was providing, such as screening?
Yeah, sadly no. The reason being that the decision for us to suspend screening on the 18th of March was because we'd moved into the delay phase. And moving into the delay phase, if you recall, moved us into people with symptoms having to self-isolate, or contacts of cases having to self-isolate. So that's the first point. The second point, which meant that we may not have the staff to run our screening services, and screening participants may not be able to attend. The second point was, with the Minister of Health and Social Services announcement on the 13th of March, it meant that the reprofiling of NHS services took place pretty much with immediate effect. Now, many of our screening programmes, we commission services from the NHS to deliver elements of those pathways, which ceased at that point. So that was the reason why, unfortunately, we had to suspend screening services.
Do you think that any of the delays that we've just covered had an impact on the response to the pandemic?
I think the microbiology, there was a natural flow to that, which travelled through the course of the pandemic. I think that with health protection, when we moved into the health protection response plan, that made life easier for us because we now had a much more clearly demarcated role. However, as we were going into a series of other waves, and clearly the scaling up of keeping on top of outbreaks and surveillance meant that we had to expand. And also at that time, if you've seen the cover letter, we knew that COVID had such a significant harm on the broader population health that we needed to be moving to a point where we could reactivate our other non-service related activities because everybody was mobilised in whole or in part. And so without additional health protection people to replace others in the organisation who'd moved into those roles, we weren't able to actually start to kick back in on our broader statutory functions around protecting the public.
And finally on this topic, are you satisfied that the current capacity is such that you are able to scale up resources sufficiently and quickly in the event of another pandemic?
I'm really relieved to be able to say we're in a much better position, and we were actually able to get 122 additional staff into our health protection. The others were vaccination leads. So we had 300 additional staff into health protection and microbiology over the last couple of years, puts us into a much better position.
Thank you. The next topic is the initial period between January and March 2020, and we're going to be dealing with the details and the chronology of events with Dr. Sandifer tomorrow, but there are a few issues that I'd like to deal with you, please. Starting with the Public Health Wales Emergency Response Plan. It's right, isn't it, that on the 22nd of January 2020, Public Health Wales invoked that plan and the response level was set at an enhanced level.
That's correct.
And if we can display the handbook, please, it's INQ 000056285, and at PDF page 16, we can see there the Public Health Wales response levels. We've just covered that the level that was set on the 22nd of January was at the enhanced level. And it says there that an enhanced response is where incidents require coordination and resources above those provided by normal operational capacity. And that type of incident is responded to by a silver group. Can you help us as to what kinds of incidents may require coordination and resources above those provided by normal operational capacity?
Yes, of course. So where we are requiring additional resources into the response to an incident, where we have significant business continuity elements across the organisation such that other parts need to be mobilised in, and where we are being asked such a volume of demand from partners that actually we need to move into another level of organisation around that.
Sorry to interrupt, but can you give us examples of the types of incidents where that sort of level of response might be appropriate?
So, for example, if during the Ebola virus disease, now we fortunately didn't have a case in Wales, but we had a highly probable case in Wales. And we reacted by obviously setting up our incident management team, and were ready and prepared that if that had been a case, we would have gone into an enhanced level of response, which includes setting up a gold command. When we were responding to NATO, so in 2014, NATO came to Newport. And in 2017, we had the UEFA Champions League Cup final. So during NATO, we had our gold equivalent running. We had our silver equivalent running in the preparation and planning for NATO.
And we can see that a major incident, the scale of the incident response required for that is a more significant mobilisation of resources and a level of strategic response.
Yes.
Is that right? Can we look at page 19, please? We can see there that when the enhanced response is activated, that would require notifying the executive, appointing a tactical incident manager, and establishing a silver group. Would that normally be done at the same time as activating the enhanced level response?
Yes.
And then for a major incident, you'd appoint a strategic director as well as a tactical incident manager, and you would establish a silver group and a gold group if needed. And
if I could say under enhanced, that's obviously that's also an option of under our enhanced level is appointing a strategic director and gold group.
And just briefly, could you please explain to us the difference between a gold group and a silver group?
Of course. So our gold group is the strategic leadership group of the organisation in responding to an incident. So it sets the objectives, it sets the overall arching response plan, it considers information coming through and adapts accordingly, and it identifies actions that the organisation needs to take. The silver group takes that direction from gold and enacts those actions, in essence. So mobilising the organisation, setting up cells or whatever that's needed.
Thank you. Can we go to the previous page, please? We can see there the escalation from a bronze group up to a silver group, up to a gold group within Public Health Wales. To the right-hand side, we can see that a strategic coordinating group might feed in. Is that a multi-agency
Yes,
group?
we feed into it.
I think the arrows go both ways.
Yeah, I know, it's probably...
But is that normally led by the police?
It is traditionally, yes. It's part of the civil contingencies mechanism.
And the tactical coordinating group?
Similarly. So in the same way, if there was a multi-agency incident like a factory fire, our strategic director would attend the strategic coordination group, and our tactical or incident director would attend the tactical coordinating group as part of the local resilience forum mechanism.
And what's the Emergency Coordination Centre Wales?
So that is the Welsh Government's unit centre that it chooses as part of the civil contingencies approach as to whether or not it establishes it. Its primary function is to assimilate data from partners across the country, to present that for government, for ministers, but also to be a centre of information to support ministers attending COBRA. So it's, if you like, it's an intelligence cell that provides some coordination of situational awareness.
So is it the government's way of nationally coordinating a multi-agency response to a major incident?
Yes, and on occasion, the ECCW may establish a national strategic coordination group itself. So if there was a national power outage, for example, we'd expect a national SCG running out of ECU, and so that the respective levels would participate in that and would feed information down and feed information back.
And does Public Health Wales have any say in whether that particular group is set up by the government or not?
No, I mean, the decision is that of ministers to establish, if I'm correct in saying, and that goes through their civil contingencies process. I think I'm correct in saying that a Category 1 responder can suggest or propose or feed in suggestions around ECU being set up, but the actual decision to establish it is that for government.
So the enhanced level response internally within Public Health Wales was set up on the 22nd of January, but it's right, isn't it, that the Silver Group wasn't set up until the 28th of January. Is there a reason why it wasn't set up on the same day?
No, I think it was probably more about ascertaining the information and understanding what was happening. What was unusual for us, though, and it's worth pointing out, is that Quentin and I had the discussion, and Quentin became strategic director on the 22nd, and we had our first incident management team.
I think it may have been the 28th. Forgive me for interrupting. I think he was appointed the lead strategic director on the 28th of January.
No, he was, yeah, sorry. So he was appointed strategic director on the 22nd of January. What happened at the following week is that we added 2 other members of the executive team to give some resilience to strategic directors, and just for formality, Quentin became the lead strategic director, but he was designated as strategic director on the 22nd, and then we had the incident management team for the incident on the 23rd, which then helped influence what the resources would be required for Silver to mobilise on the 28th. So there wasn't a delay, it was just the running of the order.
So you've told us that a gold group sets the strategic leadership and objectives in relation to a major incident. Why was the gold group not set up until the 25th of March?
So,
sorry, the 25th of February.
Yes, so bearing in mind we set up our incident management team and the Silver Group before we had any cases in Wales. So we were on a daily incident management team with the rest of the UK. We were obviously trying to help support, mobilise the NHS, and more information was coming to light, because it was still really, whilst it was very busy, it was still very, very early in understanding coronavirus and the transmission. And then on the 24th of February, we had a strategic stock take meeting with the Chief Medical Officer on a Monday, following a meeting I'd had with our incident director on the Sunday, just to say, OK, let's just take stock here. Where are we at in Wales? What's happening across the world? We were still yet to have the first case in Wales. which wasn't until, as you know, the 27th, and it was announced on the 28th. And out of that meeting, we said that actually now's the time for us to set up establish a gold group, which met on the 25th. That didn't, that preceding time, Quentin, the strategic director, was still directing the response. So I don't think there was any disadvantage in us not having that until the 25th. I think it was really more about the timing of escalation of the response.
Is it right that on the 27th of February you attended the Welsh Government Health and Social Care Leadership meeting?
Yes.
Am I right in understanding that that didn't have anything to do with the COVID-19 response?
That's a Welsh Government meeting, and obviously Welsh Government sets the agenda for that meeting.
So it wasn't to do with COVID-19?
Well, the agenda was, the COVID-19 wasn't on the agenda to begin with. It subsequently became so because the Chief Medical Officer and I did a session.
Well, I was going to ask you about your informal meeting during the lunch hour with the Director General for Health and Social Services on that day. You say you shared your concerns with him on that day about the need to scale up services and the importance of preparing and coordinating the NHS in Wales for what was to come. First of all, is it right that no minutes were taken of that informal
No, it was
discussion?
literally over grabbing food over lunch.
Did he appear to you to understand the seriousness and the urgency of what you were explaining to him?
Well, what we shared was pretty sobering. I know that the Chief Medical Officer had been engaging with the Director General before that, as had I, with email exchanges. So I'm assuming that the Chief Medical Officer, as Dr. Goodall said this morning, would have been keeping him appraised. We were significantly concerned at that point. And during the meeting, we went through where we thought the NHS needed to be. And then in the afternoon, you'll see in the agenda, I was talking about something really not important in the context of COVID. And so we changed, Chief Medical Officer and I changed that early afternoon, and he and I presented to the group, which comprised chairs and chief executives across the NHS, and shared very sobering facts around where globally, Europe, Italy, Wales were at. And in fact, that night was the first case in Wales, and it was very much about act now. Having said that, NHS organisations had already been, we'd been working really, really closely with them up to that, but I think people found it difficult to actually tangibly recognise that this was coming.
You say there that on the 28th, the first confirmed case in Wales was announced. On the 2nd of March 2020, you sent a letter to the Minister for Health and Social Services, Mr Gething, and told him that the organisation continues to be at an enhanced level of response in keeping with the other 4 nations' public health agencies. However, the organisation was being mobilised as if it was responding to a major incident, and services were being structured accordingly. Why didn't you escalate the response level to major? Why did you feel like you had to keep in keeping with the other nations?
Well, it wasn't just in keeping with the other nations, we were also in keeping with the NHS. So the rhythm that was happening was really more about business continuity than major incident. That letter followed the decision of the board on and apologies, I think I said 24th this morning, but the 28th of February, to mobilise the organisation into this. And so really by that time, it made no, whatever we labelled it, we'd mobilised the whole organisation. So we reviewed the level, the incident level, every time we had a goal meeting. And there were times where we had really quite big debates about it. And we reached the point, in fact, out of it, we provided some more decision-making guidance because we'd stopped all other services. Whether we'd have declared it as a major incident, which has different connotations for the rest of the country if the Public Health Institute has declared a major incident and others aren't at the rhythm of that. Regardless of that, that wasn't the reason why we didn't do it. We were already behaving as if we were in a major incident because the whole of the organisation had been mobilised into responding to COVID.
Do you think the Welsh Government would have taken it more seriously if you had escalated it to a major incident?
I don't think our declaration of anything would have, to be honest, made any difference because there was just such a lot of, I mean, that whatever one particular organisation had done or declared, I think in the grand scheme of things, it was moving so fast that really wasn't particularly significant to others.
Thank you. My lady, would that be a convenient time for a break? And just to confirm that Dr. Cooper is the last witness for today.
Very well. I'm sorry we're going to have to keep you a bit longer, but I promise you we will finish
That's
the
all right.
evidence today. I shall return, perfect timing, Miss Young. I shall return at 3:15.
All rise.
Thank you, my lady. Dr. Cooper, you say in your statement that from the second half of February that the Welsh government stepped up and that there was a key change of tone from the government to when, not if. And there was a commitment to stepping up and oversight across the system in Wales. Is that right?
Yes.
Do you think that that key change of tone from the government came too late?
I think, bearing in mind by the end of January, we were kind of 7 days a week as an organisation, many of us. We'd been working really, really closely with the Chief Medical Officer, as I mentioned earlier, in a pincer movement often. And there were some elements that, as I described, holding on to the NHS and running with them, that perhaps would have benefited from a little bit more performance management, perhaps, just to help people get a bit faster on some of the areas, notwithstanding the fact they were helping. So I think it would have benefited if there had been more proactive engagement earlier.
Or by ministers.
It's not necessarily ministers, because I'm not sure there would have been much that they could have done that would be that much different. But I guess it's the collective of Welsh Government that I know the Chief Medical Officer had a small team, and there was a lot of transactions happening, a lot of discussions, lots of meetings. And so to have fortified his team to be able to deal with that, but also perhaps to set the battle rhythm. And I put one of my lessons learned in my personal statement that set the battle rhythm early, you can always stand it down. So I think it would have benefited from that. I'm not saying necessarily it was health. I think perhaps more of a civil contingencies engagement earlier, back to the get the battle rhythm going, you can always stand it down. So I think it would have been beneficial if there had been broader engagement. Notwithstanding that, the Chief Medical Officer was right in the eye of the storm with us.
So is it fair to say that the Welsh Government's delay in mobilising and taking control of a national coordinated response deprived Wales of precious time to get ready, equip itself and fortify itself for the pandemic?
I'm not sure of the cause and effect. I think there was a lot happening. The first pressure point was always going to be the NHS and social care. And so we were helping ramp up the capacity, the swabbing capacity, etc., with the NHS. So I'm not sure of what tangible impact it would have had. However, I think setting the expectation for planning earlier would have helped, because. And I think I shared with the Inquiry a number of emails that literally within a week the world had changed again. So I think it was more around the planning. I'm not sure I would say that there was quite a cause and effect that the Wales was at a detriment to that. I think it was really about expediting activities and perhaps getting the local authorities involved earlier.
Could I ask for your personal statement to be displayed, please? That's INQ 000276282 at paragraph 98, page 22, please. Paragraph 98, you say, with the exception of the Chief Medical Officer and his team, with whom we were working closely from the point of becoming aware of Covid-19 in early January 2020, in my view, the wider Welsh Government did not appear to fully appreciate the seriousness of the threat of COVID-19 until the middle of February 2020, after which the Welsh Government quickly mobilised from that point. Do you stand by that?
Yes, and I think in the preceding or following paragraph, there was a lot happening at that time. There was the EU transition happening. There was some environmental challenges and the flooding in Wales. So certainly the civil contingencies team, I'm sure, would have been very busy anyway. But yes, I can't comment on what was happening within Welsh Government, so I could be doing them a great injustice. But I think it would have, for us, the main contact really was the Chief Medical Officer and the team. That doesn't mean to say that other activity was happening in Welsh Government on this, and I wasn't aware of it.
In your view, did Public Health Wales do enough to make the government understand how serious and urgent the situation was?
I think you can always do more. We did a lot. We were literally with colleagues mobilising the NHS. We were putting in place plans to we were trying to be 2 steps ahead as much as we could in those early days. And obviously the Chief Medical Officer has his own internal engagements going on within Welsh Government. But look, you can always say you can do more. I'm not sure what more we could have done. Perhaps a formal letter from me. But I'm not sure it would have made that much difference. And I think for me, what was quite an important point was when Dr. Goodall came and then the Minister came to our offices on the 11th and the 13th of March. And when you see half a very large office covered with people with high-vis jackets on, a whole national contact centre, whiteboards with tens and tens of people's contact initials on or numbers on, suddenly it becomes tangible. And to be honest, I think what was the challenge was that people they were distanced from it to an extent, perhaps it wasn't palpable to them. Yeah.
Thank you. Can I move on to another topic? It's the Seren City exercise that you've already referred to. The debrief report is at INQ. Oh, thank you. It's already up. Can we look at page 2, please? We can see there that this exercise was a strategic multi-agency tabletop exercise held on the 3rd of March 2010, and it was commissioned by you, the Chief Executive of Public Health Wales, and the Chief Constable of the South Wales Police.
2020.
Sorry, 2020. Thank you, my lady. Why did you commission this exercise?
So, as I mentioned earlier, we were watching the world, and we very quickly in January we had a growing sense of seeing the tracking, what was happening globally, Europe, and as I mentioned earlier, what was coming. But until it was here, it was difficult to get other people in the mindset that it was coming, back to it not being tangible. So on the 25th of February, I just thought we need to test a lockdown. That wasn't due to any other intelligence. I didn't have any intelligence. No one. It felt logical for us. We're an organisation that does quite a lot of exercises. So if there's something happened like Novichok within a couple of weeks, we had an exercise across Wales around Novichok. So it seemed logical that if this panned out into the worst case scenario, we needed to test something. None of us knew what was going to happen. So and when I spoke to Matt Dukes, the Chief Constable, the following day, and said, "Look, what do you think?" And he said, "Yeah, let's just do it." So we had people were face to face. So it was a face to face meeting. So it was really based on hoping it would never happen, but just to test something that we hadn't tested in Wales before.
And did the exercise conclude that a local lockdown was an effective countermeasure?
It wasn't. The exercise wasn't really set up to say yay or nay. It was really to test, should we be in that situation, where would the gaps be? And so if you looked at some of the observations and the recommendations, one was, for example, about legislation. Did we have the powers? should we be in that situation? What about the public engagement? How would that pan out? So it wasn't a kind of, is it a good thing or not? It was really just to say, what do we need to start thinking about should this situation arise?
One of the recommendations was for the Welsh Government to produce a paper on the key lessons identified in the exercise. Do you know if that was produced?
I don't know.
Also specified in the debrief was that guidance on PPE was led by PHE with input from Public Health Wales. What did Public Health Wales' input amount to?
Well, we were on. It was an ongoing input. So we, one of our incident directors, was very closely involved all the way through the pandemic. In fact, chaired the National Infection Prevention and Control Group, and was involved in the nosocomial national group as well. So we provided public health advice to help, not only to contribute to the UK guidance. So for things like infection prevention and control, it was very much a UK-led on-round guidance. As far as the specifics of PPE is concerned, our involvement was always, we weren't directly involved in procuring PPE, was providing advice, which one of the incident directors did through the pandemic. And of course, the timing of this, the 3rd of March, very soon after this, we were on an exponential experience. So the extent to which people took on the actions, I think some of the actions became real.
Bearing in mind that the thinking on lockdown as a NPI had started as early as 3rd of March, do you think that the first lockdown happened early enough?
Well, this was our let's test something. It wasn't intended to be policy, but I was here with your evidence session with Dr. Goodall earlier, and we were talking about contact tracing. So I would say there's two salient points in March. The point of going from containment to delay on the 13th of March, and then the lockdown. So that 12th, 13th of March, ourselves and colleagues across the UK, we didn't have the capacity to cope with all of the contact tracing. It was exponential as more and more countries were put on it. And also we got to the point where we knew there was now community transmission, which meant something needed to change because the model was not sustainable. Certainly the signals at that time were that we are on a rapid increase curve here. And if you asked me, do I think the lockdown should have been earlier? I think, yes, it probably should have been. I'm not a technical expert, so our colleagues would be able to give far more evidence based on that, but it felt as if at that point of the 12th or 13th of March, we ended up escalating a series of meetings with the NHS that night. And we happened to be with the Minister the following day because he came to our offices. And then, of course, the NHS reprofiling happened that evening. So I think if there was a more natural point, it was probably closer to that than the 23rd.
3 days after that exercise was the Newport versus Benetton Treviso rugby match.
Yes.
And Dr. Williams advised in relation to that he didn't think the match needed to be cancelled. It's right, isn't it, that in relation to the Wales versus Scotland rugby fixture on the 13th of March, Public Health Wales's advice was different?
Yeah, I mean, I think it's difficult because in around that time, SAGE, if I can recall, obviously we weren't part of directly as part of SAGE, but there was an evidence that was a bit equivocal about mass events and the contribution to mass events. And so Chris, that was the week, 2 days after this, Chris's advice was based on that SAGE advice. A lot happened between the 5th of March and by the time we got to the 13th of March. And our advice was in a conversation with the Minister, as we outlined in the statement. It was the day before the match was due to take place. I was with one of my other incident directors, Dr. Howe, and the discussion came up, and it was really that on the basis that even though the event itself, there may not be evidence to support the event itself, the concern really was about transport to, socialising after, and so it wasn't a formal advice, but our recommendation was for them to consider cancelling. At that point, as you know, the decision was still for it to go ahead, and then WRU cancelled it.
In your view, should mass gatherings have been banned earlier in Wales?
I mean, I'm going to play the technical expert card here because I relied on all of my team through this, so I'm not the person to ask. My personal view, which is a non-technical view, is it's difficult, isn't it, when we hadn't moved into the lockdown. So actually at that point, unless you had a case or you were symptomatic, the public weren't, or if you were in a high risk environment, whether it's hospital or care home environment where you were really feeling it, the general public were or weren't experiencing it. When we went into the lockdown, it took it to another level. So I think at that time, I think it would be if the evidence was equivocal, it was quite difficult to make an arbitrary decision. My personal views, though, is about the behaviours, social behaviours. I think that's the challenge, because if you say you can do X and you can't do Y, and Y is something that's quite large, but you still have to follow the evidence. And I think that the story, particularly of COVID in the first year, was a balance of evidence. That it's not everything was clear cut.
You said that everything was moving along very quickly and changing. In the next couple of days, there was the Wales versus Scotland Six Nations rugby match and also 2 Stereophonics concerts. It's right, isn't it, that Public Health Wales was not asked to advise in relation to those events?
No.
Do you think it should have been?
Well, we weren't going out seeking to be asked for advice on them because, to be honest, we were just so busy ourselves. Well, we were asked around the Newport Treviso, as you outlined, and we proffered advice around the Scotland Wales because it was fortuitous with the minister in the office. But I mean, perhaps it would have been helpful. I'm not sure whether it would have changed the decision, to be honest. Of course, big matches are commercial decisions that aren't a government decision to be made, and in the advance of the lockdown, that changed everything really. So I think it would have been a difficult dynamic for them because there was an order to things, and perhaps it wasn't quite the time for them to edict a decision by the WRU, for example.
Can I ask you about the Public Health Protection Response Plan that you were asked to develop by the government, by the Chief Medical Officer on the 22nd of April 2020? The plan recognised, didn't it, that Wales had had to respond rapidly to the pandemic and that it had had an unprecedented impact on society as a whole, including that many people had died. It said now was the time to prepare for the next phase of the pandemic. Was it an opportunity to pause and reflect and learn from past experiences? And so bearing that in mind, to what extent did that response plan take into consideration indirect harms from COVID-19, including, for example, on mental well-being?
Yeah, so really key point. So when we moved into the delay phase, we moved into lockdown, it did calm things down for us, and it gave us an opportunity to really take stock. We were already starting to think about the next phase before the Chief Medical Officer asked us. In fact, that triggered the question. And we'd already been doing work since April on the broader harm. So I mentioned the International Horizon Scanning report. We also had already started a health impact assessment on mental well-being on staying at home, social distancing, which was really starting to look at the impact of the first lockdown, which we produced in June. We were doing a health impact assessment on home working and agile working, and we had a series of impact assessments happening. So we already knew that the impact was really going to be exponentially significant. So when we did the Health Protection Response Plan, we intended to cover the totality of the population's health, not solely the response to the pandemic, to the infection element of the pandemic, but of course everything's connected to everything. So you'll see in the Health Protection Response Plan that we identified elements about the broader harms, and then for us as an organisation, we then went into rapid plans for us. A stage 1, which was a matter of, I think, 2-3 weeks, and then a stage 2, and then we changed our operation plan. They very much focused on the broader harms, and then in August, we set up what I called Gold 2, which was our population health a broader harms group, and we invested £1 million, moved £1 million of internal money to buy in additional capacity to help us fast track that knowledge around the broader harms for society.
The plan said that the response to COVID-19 must take into account these wider health and other impacts, but these are not addressed in this plan. Public Health Wales will conduct studies on some of the indirect effects of COVID-19, and it goes on to talk about the survey. A lot of the reports and studies that you talk about and that are exhibited to your statement post-date the publication of the report in May 2020. Are you able to say to what extent those wider health impacts were taken into consideration before the report was published?
By us or?
Yes, by Public Health.
Yeah, so as I mentioned, you've seen our structure, you haven't shown it, but we have got amazing skills around the table, including world-leading experts around the broader harms, health equity, and that's why we're a WHO collaborating centre on health equity. So we started that process from April, and that was key for us to not only help rapidly inform Welsh Government's thinking, and we did a number of themes. We did a health equities theme around the engagement survey, but also we wanted partners to be directly involved in it. And so two things, and I know we're short of time. After the Public Health Protection Response Plan was produced, we developed an operating framework for NHS and local authorities for its implementation. And then we were subsequently asked by the Welsh Government to give guidance for local prevention and control plans, which included a section around taking into account the broader harms, vulnerable people. Our broader harm stuff just continued. We did a lot of work around the broader harms. We also, really importantly, which we haven't touched on yet, was the concern around violence against women, domestic and sexual violence. So we have two parts of the organisation around adverse childhood experiences and a violence prevention unit that we run with South Wales Police. So already around about April, May, we started to do evaluations and surveys around the impact of how children and young people were experiencing violence and adverse childhood experiences. We were doing harm footprint work. So early on, we were looking at what was happening in the broader society.
In Module 1, Dr. Sandifer was taken to the response plan and he accepted that there were only 3 broad categories of vulnerable people considered in it. Those with mobility problems, those with mental health or learning difficulties, and dependents, such as children. And he accepted in hindsight that that was not an extensive enough description of who should be considered and categorised as vulnerable. Do you agree with that?
I do agree with that. In addition, I would say that in the detailed text tables about so, for example, in the population surveillance, there's quite a detailed breakdown of what surveillance. There's a lot more categories of people, different vulnerable populations included in that as far as our anticipation intention to broaden our surveillance. But I absolutely agree with that. That didn't mean that we weren't looking at those different groups because as we've talked about earlier, very early on, it was clear around the disproportionate impact that was happening. But yes, the main text, I would agree.
Mr. Goodall says in his 4th statement for this module that decisions at the start of the COVID-19 pandemic were often made without a formal assessment of the impact on vulnerable people. And in the corporate statement produced by Public Health Wales, it stated that from October 2020, the formal public health advice submissions generally highlighted the need for certain specific at-risk and vulnerable groups to be separately considered, targeted or prioritised.
Yes.
So is it fair to say that prior to October 2020, there wasn't a sufficient consideration of those people?
I don't think so, but it probably was manifesting in different ways. So as I've gone through, we set in train quite a significant multiple pieces of work to inform decisions around the breadth. So we did one of the International Horizon scanning reports was about the impact on people with disabilities. By the time we got to vaccination, which is a little bit further, we could look at the impact on people with learning disabilities. So it doesn't mean that we weren't looking at it. I think it was a challenge in what data was available as well for us to monitor it. And October, of course, prior to October, as we discussed earlier, it was a more dispersed process for us in producing advice. So in that October, particularly the 24th of October advice note, that allowed us to really central on, short succinct, these are the important things that need to be focused on. And from that point onwards, really from the 12th of October, they became very prominent.
Thank you. Can I ask you about the advice and guidance provided in relation to care homes
Yes.
and the discharge of patients from hospital? Can we have a look, please, at INQ 000336344? And if we look at page 2 of that document, we can see that there is an email initially to you stating that there's been contact from a number of care home operators and managers expressing concerns that new residents are not required to be tested for COVID-19 prior to admission. And it says, as you are aware, residents in care homes are amongst the most vulnerable to COVID-19, and the introduction of the disease into a home could constitute a significant risk. I'd be most grateful if you could advise as to whether routine testing of new residents prior to admission will take place, and if not, why this will not be the case. If we then look at the response from you above that, you say, we recognise the challenge for residential care home operators and the risk of introduction of infection through visitors, residents or staff. We are following or promoting the Public Health England guidance for residential care homes and the guidance published by the British Geriatric Society, which I've attached. The key elements of this are early recognition of signs and symptoms of possible COVID-19 infection, with recognition that presentation can be atypical in older people, and isolation of any affected residents with the use of personal protective equipment by staff. And you go on to say that new residents should similarly be assessed for signs or symptoms of COVID-19 infection, and those affected isolated as appropriate. If new residents or existing residents do not have symptoms prior to admission, there is no value in testing for the presence of the coronavirus. The test is designed for patients with symptoms, and therefore we don't routinely test new residents prior to admission. Now, we know that later, Public Health Wales issued guidance which was consistent with that. And then later still, the government changed the policy so that everyone coming out of the hospital was being tested in light of the evidence of asymptomatic transmission. Do you now accept that your original advice was wrong?
Yeah, it's just taking into, I guess, the context at the time. This was before Welsh Government had made decisions around testing in relation to care homes. So there was no policy decision on testing at that point. The reference around testing was that at that point, the case definition didn't include residents in care homes, if you recall, other than people who were symptomatic. And so what was, if someone had a fever or a continuous cough, that was the indication for tests. So the testing world was in a different space. And the other element that was a challenge was that if someone had a negative test, it didn't mean that they weren't incubating COVID. So at this point in time, the world changed significantly as we went through April and into May, and we had about 1,000 tests a day. So it was a really challenging time around testing.
I'm going to ask for one more document to be displayed, please. It's INQ 000191663. And if we look at the, we can see that this is a PHE care home discussion paper dated the 18th of April 2020. And the third paragraph, can we see there that it says PHE arranged swabbing of all residents and staff in 6 care homes. And the results from 3 was that there was very high positivity, 50% plus, only 30% with symptoms. Of staff, 45% were positive, of which around 30% had symptoms. For those symptomatic, around 50% chance of symptoms. And then below that, it says, so symptoms poorly predictive of infection, therefore a poor trigger for control measures. Did Public Health Wales do any kind of investigation like this by going into care homes and seeing for itself what the rate of positive cases were in symptomatic and asymptomatic cases?
We did further, I think about 3 or 4 weeks after this, we looked at a series of care homes that hadn't had outbreaks, and we looked at when we had more testing capacity or system testing or care home testing. What I would say in relation to this, though, on the 18th of April, we had been routinely testing symptomatic residents in care homes since we had the test available. And on the 6th of April, we started testing symptomatic care home workers as part of the critical workers policy. So, because another element of this is about the concern around the spread by staff. So everybody was learning as this was materialising. And this was at the time as well when we were working with Welsh Government to amend the testing policy based on Public Health England's document on the 15th of April, which was the Adult Social Care Plan, in which all residents on discharge would be tested. So on the 22nd, the policy changed here, and I think a letter came out from the Chief Medical Officer and the Deputy Director General responsible for social care, outlining that everyone being discharged will be tested, and that there will also be a more prompt response into clusters or incidents in care homes. So this was quite a critical time that also helped change the Welsh Government testing policy.
Given that this was such an important group by size, vulnerability and the severity of adverse impact, do you think that that kind of investigation ought to have been done before you were advising that asymptomatic people did not need to be tested?
Well, the advice around asymptomatic testing of asymptomatic people was advice that was being worked through not only by us but also as with this the UK-wide incident management team, and the world was evolving around evidence of, and there's a difference between asymptomatic transmission and someone who has it who is asymptomatic, as you know. So we were learning together on this, and the PHE6 study, which is what it became known as, just because that was England didn't mean that we were all learning from that. So later on in the pandemic, we all did quite a lot of different studies within the countries, but this was just as important to us, regardless of which country it had been done. We didn't necessarily needed to fast-track one in Wales to not take this on board. And our challenge was testing capacity. By the time we got at this point, we'd increased to a couple of thousand, and then in May we were able to really expedite all of testing. So I think on the 2nd of May we did all testing of symptomatic and asymptomatic staff and residents in care homes with a new outbreak, and then 2 weeks later the same in care homes without an outbreak, because we were concerned, which is back to your question, we were concerned about what was happening in places that hadn't logged an outbreak that potentially could have transmission that wasn't being picked up.
Thank you. In relation to public health communications, you say in your personal statement that in your view an area that could have been better was in relation to clearer public messaging when there was a clear divergence in restrictions compared to other UK nations. Can you explain what you meant?
Yes, I think it was a challenge because regardless of the policy strapline or the public communication, you've also got the media. So in the first few months, the UK media tended to default to the decisions that were being made by the UK government vis-à-vis England. That did improve, and as the months went by, they would differentiate. This is what's happening in Wales, this is what happening in Scotland, Northern Ireland, England. But in the first few months, it became really confusing for people. I think when all of the countries started to diverge, particularly coming out of that first lockdown, I think there were a number of occasions where a strapline of a policy created quite a lot of problems in other countries that were still being a bit more cautious. I don't think there's any easy answer to solve that. I think the early engagement with the media is really key, because people will tend to default perhaps to the UK rather than the national. So whether there is an opportunity to work more closely with the media at the outset, possibly. The other elements really was about ensuring, which we worked closely with the Welsh Government on after a few months, was the behavioural insights messaging. So if you're going to change a message, you have to perhaps tailor it more to the view of the mood music of the population, and then also further tailor it to different population groups. So I think there is learning in there for us.
Thank you. And finally, on reflection, is there any other learning that you would like to highlight? Is there anything that you think Public Health Wales could have done better?
Oh, I'm sure there's lots and lots of things that we could have done better. I think three key learning points, really. One I mentioned earlier was just get the battle rhythm up and running. The second, I would say, is about respective roles and responsibilities, because I think they were muddy for the first few months. And having us all lived through this, I think that has improved. There was a health protection review undertaken that the Chief Medical Officer commissioned that was helpful to that. So I think that's the second one. And I think the third one is very much about the welfare of staff. So for us, we spend a lot of time around the well-being and welfare of our staff, and trying to do as much as we can on that, because people expect an incident to have a beginning, a middle, and an end. This just kept going, and so the sustainability, be it a care home, be it a hospital, be it an organisation like us, I'm not sure. I'm not sure enough has been done to say, okay, well, how do we really try and address that? We've got more staff now, which is great, but that's not the same as everywhere. So I think that's a continued challenge that I think something needs to be factored into what we can do for learning.
Thank you. My lady, those are all my questions. I believe there are
Thank you
some
very
questions
much.
from core participants.
There are. Shepherd.
Good afternoon, Dr Cooper. I appear on behalf of Covid-19 Bereaved Families for Justice Cymru, and my question focuses on ventilating indoor spaces and in particular public communications regarding ventilation. I don't propose you bring it up on the screen, but in your corporate witness statement, you set out some of the public messaging campaigns that Public Health Wales has a role in delivering. These include the Wash Your Hands message, the Stay at Home message, and an advertising campaign to encourage pregnant women to get the vaccine. But what's not on the list is a campaign regarding the importance of ventilation. Firstly, was Public Health Wales involved in a public messaging campaign about the importance of ventilation as a mitigation against the spread of Covid-19?
I can't recall if we were. Dr. Sandoff has given evidence tomorrow, so it'd be worth asking him. So we may have done. I'm not familiar with it, and we didn't put it in the statement, so that may have been no.
I just want to provide some context. There's a document, INQ 000220539. Just for context, this is a paper from the Welsh Government, and it just sets out all of the advices that SAGE provided in July of 2020. And at row 39 of that document, just wait for it to come up. So I don't know whether it's possible to get row 39 up. I appreciate it's an Excel spreadsheet, so it's a bit different. We can see in column, wait for that to come up.
Yeah.
So there we are. We can see in column E, and it's in bold actually, it sets out that SAGE endorsed the EMG paper on airborne transmission. So EMG, the Environmental Modelling Group, a subgroup of SAGE. In column F, we can see that it's a document that was entitled Role of Aerosol Transmission in Covid-19. And this was endorsed by SAGE on the 23rd of July. At this point, Public Health Wales had access to SAGE advice papers, is that right?
Yes.
And what's said is that SAGE noted its findings around the limitations of face shields and visors and on the importance of good ventilation. So if Public Health Wales didn't get involved in a public messaging campaign about ventilation, are you able to say why not?
Well, we were involved closely in all of the advice around ventilation, but particularly in places like schools. In fact, we spent a lot of time providing support. The campaign, it's maybe worth just saying that the campaigns originated in two ways. So a lot of the strapline campaigns, as I would call them, were Welsh Government. We didn't design them. We disseminated them, but they weren't our campaigns. We did lead on the campaign to encourage pregnant ladies to get vaccinated. But I think it's a fair question. So I guess my answer is just because we didn't do a campaign doesn't mean we weren't involved in it. But I think it's a fair challenge back to say, well, did we think to do one? I wasn't involved in all of our technical conversations, so Quentin may be able to enlighten further. But I think it's a fair question, actually, and maybe that's something that we need to reflect on.
If I could just one follow-up question. Is the reason why it's a fair question perhaps because as understanding about airborne transmission evolved, the focus perhaps needed to move away from washing hands towards things like ventilation? Is that reasonable?
I think it would be both. I mean, the hand hygiene was always and will always be a prominent aspect of infection prevention and control. I think from the ventilation element, there was a lot of guidance on it. Of course, it was different in different environments. So whilst you can put clear principles, the actual public health advice would be different depending on the environment. But I think it's a fair question, and so I would say it's both and I'll take it back to the branch as well and have the conversation about, is that something that we should think about doing? Should we be in this situation again?
Thank you very much, Dr. Cooper. Thank you, my lady.
Thank you, Ms Shepherd. Ms Fuberter.
Thank you, my lady. Good afternoon, Dr. Cooper. I represent John's campaign and Care Rights UK. You've explained this afternoon and in your statement about the role of Public Health Wales, including to provide advice on the indirect harms of the pandemic on population health and well-being, and that your advice recognised decisions needing to balance considerations which included the wider harms of interventions. If I could bring up INQ 000251938, this is the witness statement of Dr. Chris Williams, who I think you're familiar with. And when we get there, I'm going to turn to page 6, paragraph 25. And what Dr. Chris Williams states about halfway down this paragraph is he refers to the availability of other viewpoints on the wider questions being very helpful in moving beyond a strictly infection-focused assessment of harms and benefits. Do you agree with that? And do you accept that the focus ought also to have included the wider harms caused by restrictions themselves?
If I can clarify a question, do you mean in relation to what we were doing or in relation to what Wales was doing?
So do you agree that there was at least initially a strictly infection-based focus, and do you agree that that ought to have considered the broader harm?
So if I answer for us, that's probably easier.
Yes.
So I would say January, February, probably the first part of March, it was absolutely about protecting the public and preventing infection. I mentioned earlier, Professor Mark Bellis is one of our former directors. So Mark, very early on in the pandemic, he headed up our WHO Collaborating Centre, was saying you've got to start to think about the broader harms, which is why in April we started doing that work. And so whilst it wasn't necessarily appearing in our advice, there was a lot of work that we put in train because Mark was particularly focused on it. I think what Chris is also alluding to is that when we got into the more formative advice note stages, Mark would be part of those discussions. And we would have quite colourful conversations because it was that balance of our health protection team saying, we need to be really restrictive to prevent spread. And there's Mark saying, well, there's the mental well-being and the different aspects of the impacts of the population group. So I think that's probably what Chris was saying. But no, I would say in January, February, March, our focus was about trying to prevent the spread of the infection. And then from April, we really started to increase our work on the broader harms.
I'm going to now look at INQ 56334. And this is a Public Health Wales document from the 10th of March 2021, so the following year. And at page 4, the second paragraph from the bottom. So the document itself was a briefing note to the Minister for Health and Social Services. And the second paragraph from the bottom refers to further restrictions on individuals and communities should be informed by a much more sophisticated understanding of the benefits and harms of such actions. So why was the understanding of the harms caused by COVID-19 measures still, as of this time, so March 2021, not sufficient?
Again, whether it's a question for us or a question for Wales, I think by March 2021, I think there was, to be fair to Welsh Government, much more of a recognition around the harms in the way that they were making the decisions. And it was the balance of the harms around restrictions and the order of letting things or releasing things. I think for us, I'm not sure that'll ever go away as a statement. I think we know before we got into COVID, we were facing challenges in the demographics of society. And then obviously since COVID, we've had the cost of living crisis, we've got the conflict in Ukraine, and climate change. So they all superimpose on the broader harm. So I don't think we can ever do enough on that. But as far as the restrictions are concerned, we moved into a slightly different world from March 21, and what we were trying to position Welsh Government to is to have a much more structured way of tracking the numbers as well, because we can talk about it, but if you can't measure it, it's quite challenging. Later in that year, we developed a much broader population health dashboard that included all of the proxies into different parts of society.
Just focusing specifically on this time frame and what this Public Health Wales document is saying, what steps were necessary in order to obtain the kind of more sophisticated understanding identified in this document? What kind of concrete things do you think this document is alluding to?
Yeah, I think it's measurement. And we kind of go on to say it in the document. So at the time, there wasn't one that we were aware of centrally held point that was tracking the broader harms, be they about well-being, be they about impact on health services, be they about morbidity. So there was a Welsh Government, no doubt, and wasn't close to it, had the socioeconomic tracking, but we weren't aware of anything that was actually measuring the specific harms around health and well-being. Now, some of these take years to measure, to be fair. So it's not an easy thing to do, but our point really was more about, as we said in October 2020, we said this again, and this followed the meeting with the Minister the previous fortnight, that you've got to start balancing them. And if the October 24th note that we sent was about getting into a different relationship with the public, in recognition of this, and factoring that into the pacing and the order of restrictions. So this covered quite a few areas, I would say.
Thank you. Just moving to a slightly different topic around communication. You've explained today and in your statement about Public Health Wales's role about ensuring communication and ensuring there's consistency and guidance. If we could bring up document INQ 000181725. While it comes up, I'll tell you what the document is. It's the Older People's Commissioner, Helena Hare-Colotz, produced a report called Care Homes Voices, a snapshot of life in care homes in Wales during COVID-19. And this is a document from June 2020, so fairly early on. And when we get there, I'll just refer to page 12 of this document, and the first paragraph in particular of page 12. And what this paragraph says is that there were a number of responses from care home managers and staff highlighting difficulties in accessing crucial information and guidance, and particularly the second sentence of this paragraph. Particular issues were highlighted about the amount of rapidly changing information that care homes were receiving, often from multiple bodies, which was often confusing or contradictory. Do you accept that there was sometimes confusing guidance that was contradictory and unclear?
I think it was very confusing for care homes insofar as the guidance was changing very, very quickly, and sometimes there was an occasion where a change to policy was announced and none of us knew it was going to be announced. And so our call centres were going wild, and we didn't know the decision had been made. So it was a very busy time, particularly for care homes, I would say, around that February, March, April into May. So I would accept that.
And specifically on visiting in care homes, do you accept that there were some deficiencies in visiting guidance? And if so, what kind of thing would be needed to ensure that guidance is clear, consistent and comprehensive in relation to visiting?
I can't recall exactly the specifics around visiting, as I'm not as close to it. But we did put guidance, I think guidance was circulated in March, middle of March, around really that, trying to reduce the ingress of infection, from different sources, including visiting. I mean, it probably wasn't until the middle of March, end of March, where that changed. I think there are areas with care homes that I think we could have been clearer. Welsh Government could have been clearer, I think if we should have earlier on, whilst we set up an enclosed setting cell, it was the only port of support for the care home sector. I think we should have set up a settings-based meetings earlier so that we could really understand what was materialising on the ground within care homes that would have been more helpful to have more or less guidance in. It may not have changed the public health advice, so I would recognise it.
And just on that, was there a member of the team who was responsible for producing guidance who fully understood the needs of people in care? And if there wasn't, do you think that would be something that would be helpful going forward?
We had a lot of members of the team in our enclosed setting cell because we accelerated it very quickly. We had people who had quite a strong experience around the care home setting. We did engage with particularly Care Inspectorate Wales, but I would absolutely agree with what you've said. I guess what I'm alluding to is not just in care homes, but having reflected a lot on this, we were working with partners, but I think that if we were to run this again, I think we should have that settings-based, real lived experience, people involved early on in the development of guidance. As I say, it may not change the public health evidence, but I thought this was a really powerful document, by the way. And having read a lot from colleagues in care homes, the reality of, well, if you say to do X, do you realise how challenging that is? And then I guess my final point on this is all the experience that care homes now have around infection prevention and control is how do we help retain and support that for people.
Thank you. Last week we heard from Stephanie Howarth, Chief Statistician, and she confirmed that the Knowledge and Analytical Services only became involved in data collection and analysis after the early stage of the pandemic. And that if they had been asked to advise earlier on, they could have avoided various errors in misreporting. Why didn't Public Health Wales ask CAS to assist at the outset of the pandemic?
We were just exponentially increasing our requests to meet the demands from a data perspective from Welsh Government. I guess the question is, they could have offered. You know, it's a bit of a two-way, I would suggest. We were working really closely with the Chief Scientific Officer for Health, with the NHS Delivery Group, who were looking at the activity data for the NHS, who we tend to have those connections with. We had worked less so with the Knowledge and Advisory Service, if you say that correct. So if we'd had stronger relationship with them, we would have thought to do it. I did see the Chief Statisticians for Health evidence, and the part of the challenge, the flip side. So if we'd have thought, we'd have done it, but also it would have been nice for them to. I think it was probably incumbent on both parts. But the challenge, though, is data's only as good as it being populated at source, and we had some real challenges on that for health and social care. So there's some human behaviours in there.
I'll just move on because I've got one final question. I'm conscious of time. Last week, again, we heard from Dr. Chris Williams, and he said that he was aware that asymptomatic transmission could be as great as 40%, and this is following the Diamond Princess cruise ship data. And he said he couldn't recall whether he told the Welsh Government, but his main role was to keep Public Health Wales updated. Were you aware, was Public Health Wales told about Dr. Williams' awareness of possible asymptomatic transmission in late February? And if so, what steps were taken by Public Health Wales in relation to that?
Yeah, I think Quentin would be closer to. I wasn't part of the incident management team. I can't imagine Chris wouldn't have shared that. I would have thought, because everyone shares the evidence because it's a duty to. I would have thought, although I didn't attend the incident management team, which was a national incident management team, that not just this, but anything that come through, that would have been, there'd have been a discussion at various times, because it was an evolving picture around asymptomatic transition, that would have been discussed and debated at the incident management team, and any other further evidence that came through, I would have thought that would have been debated there.
Thank you. Thank you, my lady.
Thank you very much indeed. So that completes the evidence for today.
It does, my lady.
Thank you very much indeed, Dr. Cooper. Very grateful. I'm afraid I'm not sure I can give you a guarantee that you won't be asked to help again. I'll try and limit it. I do understand the impositions that asking people to give evidence makes upon them, apart from us providing the statements and things, but we're very conscious of it and we'll only call on your help if we need it. So thank you for what you've done so far.
Thank you.
10 o'clock tomorrow, please.
All rise.